So the question number 4 is reverse splitting of second heart sound is most commonly seen in AST, severe MR, LBBB, pulmonary hypertension. So we have S1, S2, S3, S4. So 4 heart sounds are important. So we have to talk about S2. S2 is second heart sound. It consists of P2 and A2. P2 is because the closure of pulmonic valves, means valves in the pulmonary artery. A2 is because of the closure of aortic valves in the aorta. When will closure of pulmonic valves take place? When the blood from right ventricle is finished, whatever it has to push, it has been pushed. Now closure of aortic valve occur when the blood from left ventricle has been pushed out. So this is the concept of P2 and A2. Now normally from P2 and A2, which will occur earlier, P2 or A2? So it will be A2. Why? Because left ventricle has great musculature, has higher musculature or larger musculature in comparison to the right ventricle. So the blood from the left ventricle will be finished first and then from the right ventricle. So if we see normally A2 will come first with the P2. So there will be S1 sound, and in the S2 sound there will be first A2 and there will be P2. Okay, but what happened during inspiration? So what happened during inspiration? So we have to see that during the inspiration there is normal splitting, what we call normal splitting. What happened? That during the inspiration there is a drop in the intrathoracic pressure. So there will be decrease in the intrathoracic pressure. So it will be just like the negative pressure, and there will be sucking of the blood from the great vein. So venous return will increase. So right ventricular filling will increase. So right ventricular stroke volume will increase, and so increase right ventricular ejection time. So it will take higher time. It will take more time for the blood from the right ventricle to eject out, and therefore there will be delayed closure of the pulmonic valve. So there will be delayed closure of the pulmonic valve. Second thing which will happen is during the time of inspiration, the pulmonary impedance, that is the capacity of the pulmonary circulation, will increase. So pulmonary impedance will decrease. It will also occur during inspiration, which contribute to delayed closure of the pulmonic valve. So if we see this diagram, we can see that during the time of expiration there is S1, then there is, in the case of S2, there is A2 and there is P2, which is normal. But during the time of inspiration, S1 is there, but P2 goes delayed. Why? Because of, we have seen that during the time of inspiration the venous return will be higher, and secondly the pulmonary impedance will be lower. So it will take more time for the pulmonary valve to close, because still the blood from the right ventricle is coming. So it will not close early, so it will be delayed. So it will be normal delay. So during the inspiration normally P2 get delayed. Now which are the conditions in which it will be delayed more? So those are known as the wide splitting. So what are wide splitting? So wide splitting is that during the time of inspiration, this is condition that delays RV emptying. So right ventricle will be emptied later. So there will be more delay in the right ventricular emptying. And in those conditions, there will be wide splitting, means that during the time of inspiration, the right ventricle will take more time to empty. And this is seen in the case of the pulmonic stenosis and the right bundle branch block. So there will be pulmonic stenosis or right bundle branch block. Why is it so? Pulmonic stenosis means there will be more resistance for the blood from the right ventricle to go into the lungs. And in the right bundle branch block, the musculature, there's a problem in the right ventricle. The right ventricle will not be able to push the blood into the lungs at time. So that's why it will causes delayed pulmonic sound, especially on inspiration. So there will be exaggeration of the normal splitting. So if we see the diagram, in expiration there is S1, then there is, in the S2 there is A2, P2, but during the time of inspiration the P2 get delayed, and we have seen the condition that is happened in the pulmonic stenosis, and you see in the case of the right bundle branch block. Now there is fixed splitting. What is fixed splitting? Fixed splitting means that there will be delay, that there will be splitting occurring, but it will occur in both expiration plus inspiration, both. So this is seen in the case of the ASD, atrial septal defect. So in the case of ASD there is left to right shunt, because always there will be higher blood pressure in the case of the left atrium. So the blood will always go from the left atrium to the right atrium. So always there will be pressure higher, so the blood will go from the left atrium to the right atrium. Either this is inspiration or expiration, it will always go. So there will be increased right atrium and right ventricular volume. So increased flow toward the pulmonic wall, such as regardless of the breath, pulmonic closure is greatly delayed. So if this see this condition, it is getting delayed in both in expiration as well as in inspiration. So this is known as the fixed splitting. Fixed splitting. So what is the difference between wide splitting and the fixed splitting? In the case of the wide splitting, the widening is occurring only in the case of the inspiration, while in the case of the fixed splitting, it is occurring in both inspiration and expiration, because the atrial septal defect is the mechanism is operating in both the conditions. Either this is inspiration or this is expiration. So we have to remember fixed splitting occur in the case of the atrial septal defect. Now there is paradoxical splitting or the reverse splitting. So in the above conditions, we have seen that it was always the P2 which was getting delayed, but there are certain conditions in which the left ventricle is taking more time to eject its blood out. So in that case, the A2 will be getting delayed. So this is heard in the condition that delay aortic valve closure, that is the aortic stenosis and the left bundle branch. Just like we have seen in the case of wide splitting, there was pulmonic stenosis and right bundle branch block. But here we have seen this is just like pulmonic stenosis, we will go for aortic stenosis. Right bundle branch block, it will be left bundle branch block. So in that condition, the A2 will be getting delayed. So if we see the diagram, in the case of the expiration, it is there P2 and then A2, and then inspiration, the A2 is again delayed. Okay, so the A2 is getting delayed. So those conditions will be the aortic stenosis and there will be left bundle branch block. So this is about the splitting. So we have seen normal splitting, wide splitting, fixed splitting, and reverse splitting. So ASD, we have seen it is the fixed splitting, not reverse or fixed splitting. So regardless of inspiration or expiration, there will be splitting. Severe MRC, this is the heart, right atrium, left atrium, right ventricle, left ventricle. So it is saying that there is a severe MR. So mitral valve is there is mitral regurgitation. So when the left ventricle will contract, the blood will not only go to the aorta, but also will go into the left atrium. So there will be less blood in the left ventricle to eject out. So that's why aorta will come more earlier. So it will be earlier. So that's why there will not be widening. So there will be more widening. So it not be the splitting will be more. So in this case there will be more splitting. Your wide splitting. So this is not the condition. Left bundle branch block, yes, we have seen that it is the left bundle branch block, and aortic stenosis in which it will be occurring. So left bundle branch block is answered. In case of pulmonary hypertension, so the lungs will be provided more resistance for the blood to come out. So that's why there will be more widening. So there will be wide splitting. So pulmonary valve will close later. So there will be wide splitting. So answer will be left bundle branch block. So it will be left bundle branch block. So this will be the answer. Now coming to the fifth, which of the following are the major criteria and the Jones criteria for the acute rheumatic? So it should not be just Jones criteria, it should be revised Jones criteria. So Jones criteria is very, very primitive, but it was the revised Jones criteria for the acute rheumatic fever. So there are certain criteria to diagnose the acute rheumatic fever, and these criteria are in the two population. One is the population with the low risk population, and there is a high risk population or moderate to high risk population. So there is moderate to high risk population. So for moderate to high risk population, in the low risk population, again there is major criteria and minor criteria. Again in the moderate to high, so there is major criteria and there is minor criteria. Because nothing in this given this question, so we will consider it to be low risk population only, the general population only, not the moderate to high risk population. So this is in the revised Jones criteria. So chorea is a major criteria. Erythema marginatum again is a major criteria. Subcutaneous nodule again a major criteria. Polyarthralgia is a minor criteria. But remember that polyarthralgia is a major criteria in case of moderate to high risk population. So if the population you are considering is moderate to high risk population, then you will consider polyarthralgia to be a major criteria under the Jones criteria. But because here it is not mentioning it, it's a major moderate to high risk population, that's why we will consider to be low risk population only. And the answers are accordingly also in the option, none of the options giving the all of them to be correct. So that's why it is taking, it means it is also taking it to be a low risk population only. So polyarthralgia will not be the answer. So answer will be 1, 2 and 3. So it is a 1, 2 and 3 is the correct answer. Now coming to the criteria. So these are the 2015 AHA revised Jones criteria for the diagnosis of rheumatic fever. So there is low risk population, there is moderate and high risk population. So carditis is present in both, either it's clinical or subclinical. Arthritis is present in both, but in the low risk population it's only polyarthritis. But in the case of moderate to high risk, it is not just polyarthritis, it can be monoarthritis, and it is not just itis, not just inflammation, but only pain can also be one of the criteria. So polyarthralgia is criteria in the case of moderate to high risk population, while the polyarthralgia in a low risk population is a minor criteria, while the polyarthralgia in the moderate to high risk population is a major criteria. So then chorea in both of them, erythema marginatum both of them, subcutaneous nodule in both of them. Minor criteria, there is polyarthralgia, in the moderate to high risk is monoarthralgia. Fever more than 38.5 degrees Celsius, here 38 degrees Celsius. ESR more than 60 mm in the first hour, here it is ESR more than 30 mm in the first hour. CRP in both of them, 3 more than 3 more than 3. Prolonged PR interval, we know that we take PR interval by accounting for the age variability. So, but we have to take this criteria only if the carditis is not a major criteria. Okay, you cannot say that, okay, we have taken carditis also and we have taken the prolonged PR interval also. This cannot be happen. Now coming to the sixth question. A 70-year-old man with dyspnea on exertion. So whenever there is exertion, this breathlessness has been found to have a single second heart sound. So S2. Again, we have talked about S2, which consists of the P2 and A2. It's a single heart sound, but there is only just one heart sound. Either P2 is absent or either A2 is absent. It means and a loud diamond-shaped rough quality systolic murmur. So when the systole is occurring, this systolic murmur. So there's a diamond-shaped systolic murmur, which is best heard at the right second intercostal space. Now the answer is very clear. So it is being heard at the right second intercostal space, which we know is the space for the aorta. And this is the aortic space on auscultation, aortic space. And it is radiating toward the right carotid artery. Now this become more specific that this is talking about the aorta only. So which one of the following is the likely? So this is the aortic stenosis. So answer will be aortic stenosis. Now, so about the seeing the question. So what are the features? Which is the key clinical feature in this case? There is 70-year-old man, dyspnea on exertion. This single heart, second heart sound. It means A2 is absent. Why there is single second heart sound? Because A2 is absent. There is a loud diamond-shaped murmur, and the type of murmur is ejection systolic murmur. So whenever the blood is being ejected from the left ventricle, the aorta is going to provide it resistance. So the flow of the blood will not be smooth. So there will be murmur seen. So it's a loud diamond-shaped ejection murmur. You can see it here. There's a diamond-shaped murmur, ejection systolic murmur. It is best heard in the second intercostal space. So it is best heard in the second intercostal space, and it is radiating to the right carotid artery. So why is it aortic stenosis? Because it is common in elderly. There is degeneration and there is calcification of aortic valve. It is crescendo, decrescendo systolic diamond-shaped murmur. It is best heard at the right second intercostal space because the aortic area, it radiates to the carotid artery. In the severe aortic stenosis, A2 either will become soft or it will become absent. There will be only single S2. There will be dyspnea on exertion, which is the classical symptom. And so in the aortic stenosis, the normal aortic valve is like this. This tricuspid valve. But in the case of aortic stenosis, it will become the calcified. Now, if we go for the auscultation area, which we talked about, so there is aortic area, pulmonary area, tricuspid area, or the mitral area. So aortic area is in the second intercostal space, right sternal border. Again in the second intercostal space, but on the left sternal border, there is pulmonary area. Then in the fifth intercostal space, there is tricuspid area on the left sternal border, while in the mid-clavicular line, it will be the mitral or the apex area. Now radiation of the murmur. So in the aortic stenosis, it will radiate to the carotid artery. S2 in the case of aortic stenosis, so there will be severe aortic stenosis. So A2 will become either soft or absent. So there will be single S2. So normally A2 is before P2 because we have talked about in another question that because the musculature of left ventricle is larger than the right ventricle, so A2. So the aortic closure will happen first because the blood from the left ventricle will be finished first. So A2 will first, then there will be P2. But because now A2 is absent, so there will be only single S2 and it is P2 only. So A2 is inaudible. What is the classical clinical triad? So they generally ask for the severe aortic stenosis. There is a clinical triad which is also known as a SAD, SAD, S for syncope, A for angina, and D for dyspnea or heart failure. What is the pulse? Pulse is commonly the name is very unique. The pulsus parvus et tardus. So very specific finding. So there is a pulsus parvus et tardus, means slow rising. So it is slowly rising and it's a low volume pulse. So it's a aortic stenosis. So differential diagnosis we have seen. So there's aortic stenosis. We have seen there's ejection systolic murmur or crescendo decrescendo murmur. In the case of pulmonic stenosis, there will be ejection systolic murmur. In the case of VSD, there will be pansystolic or harsh murmur. In the case of PDA, there is a continuous machinery murmur, systolic and diastolic both. So it will be seen in both systolic and diastolic, because either it's systolic or it's a diastolic, the pressure will always be higher in the aorta than the pulmonary vasculature. So blood will always be growing from the systemic vasculature to, from systemic vasculature to the pulmonary vasculature. Now, aortic stenosis will be best heard in the right second intercostal space because that's an aortic area of auscultation. Pulmonary stenosis will be seen in the left second intercostal space, will be heard in second left intercostal because it's a pulmonary area. VSD will be seen in the left lower sternal border, and the patent PDA will be seen in left infraclavicular area. Now, radiation in the case of the aortic stenosis will occur. The murmur will be radiated to carotids. In the pulmonary stenosis, there will be left shoulder or the back. VSD, there is no radiation, and the PDA will be radiating to the back. Now, S2 will be, in the case of aortic stenosis, the A2 will be soft or absent. So, there will be single S2 in severe aortic stenosis. In the pulmonary stenosis, as we have talked about in the previous question, there will be splitting. So, there is a wide splitting. In the VSD, S2 is normal. In the PDA is usually normal. So, this was the question on the aortic stenosis, which can be asked again. Let us read it again. After doing all the explanations, let's read it again. So there is a 70-year-old male, so there will be an old male with a dyspnea on exertion, okay, has been found to have a single second heart sound. Why? Because A2 is absent. And a loud diamond-shaped, rough quality systolic murmur, which is best heard at the right second intercostal space, radiating to the right carotid artery. So that's now become clear. Coming to the question number 7. Which of the following is the appropriate scoring system used to assess the risk of the stroke in patient of the non-valvular chronic atrial fibrillation? So there is an AF. So there is a patient of AF, chronic AF. So you will start the patient on the oral anticoagulants because you do not want the thrombus to occur. But we should know that because the patient is on anticoagulant, there is risk. There is risk of stroke. So what will be the scoring system so that we can find what is the risk in this patient? So the answer is this: CHA2, DS2, VSC. Now, what are other scoring system that is being provided? So let's go to explanation. So whenever we give this thing, we have to find out that there is two criteria: CHAD, S2, VS2, and Hasblat scheme. So what is CHAD2, DS2, VST? It's a congestive heart failure given score 1. Then hypertension 1, if more than 75 year age 2, diabetes mellitus 1, stroke or TIE or T initially 2, vascular disease prior MI, peripheral arterial disease or aortic plaque 1, age more than 60 to 74 year 1, sex category female gender 1. So maximum score is 9. This other criteria which is known as the Hasblat criteria. Hasblat criteria is not about the stroke, it is about the bleeding risk. So that's about the stroke, and that is about the bleeding risk. So hypertension, uncontrolled BP score 1, abnormal renal or liver function which can be 1 or 2, stroke 1, bleeding tendency or predisposition 1, labile INR 1, age more than 0 1, drugs concomitant aspirin and acid oracle 1. Score is again 2. So has bleed and CAD, these two both are associated with the whenever we are using oral anticoagulants in case of chronic AF, atrial fibrillation. But Hasblat is about the bleeding tendency, that what is the risk of bleeding tendency in this patient, while this CHAD2 DSOS is about the stroke. Now coming to AM4. What is AM4? So first we should put it that the answer will be this: CHA2, DS2, VSC, and they can ask that what is the total score that can become. It is 9. So this is the answer. Now coming to AMT4. So Hasblat we have seen just a bleeding tendency. AMT4. So AMT4 is abbreviated mental test. We are going to ask 4 questions in this. Sir, what is your age? What is your date of birth? What is the place? What is the year? So score less than 4 means it's abnormal, and you have to go for the prompt for the cognitive screening. So this is about the AMT4, the option abbreviated mental test. So this we have finished. AMT4 also, Hasblat also. Now curve 65. So curve 65 is simple. It's for the pneumonia. So in the curve 65, C stands for the confusion, which is defined as the mental test score of less than 8, or disorientation of a person about the person, place or time. So point is 1. Uremia, blood urea more than 7 millimole, 19 milligram per deciliter. R4 respiratory rate more than 30 breaths per minute, BP systolic less than 90 or diastolic less than equal to 60. Even more equal to 60 means you have to give the score as 1. Age more than 65 years, 1. So total point we have to find out. So if the total points come out to be 0 or 1, so that's a group 1. The mortality is low, about 1.5%. It is low risk and you have to consider home treatment. But if the score is 2, now the mortality rate become intermediate. Now consider hospital supervised treatment, which can be short stay inpatient or hospital supervised OPD basis. More than 3, group 3 mortality is high. Manage hospitalized severe pneumonia. You should consider the admission in the ICU, especially if the CUP65 score is 4 or 5. So 0 or 1, you have to give the OPD basis. Here you have to admit the patient in the ward, or just a supervised one. He can go home, but the hospital has to supervise it. In the case of 3, you have to go for ICU admissions. So go for ICU admissions. So curve 65 criteria is for the pneumonia, that where you have to treat the pneumonia in the OPD basis, ward basis, or the ICU basis. Now coming to question number 8. Consider the following statement with regard to the pulmonary embolism. So there is a pulmonary embolism. They are asking which of the statement given is correct. So they're asking unexplained breathlessness is the most common symptom. Yes, this is again true. So you have find out all things that breathlessness is there, but you cannot explain it by the conditions. So that's the unexplained breathlessness, the most common symptoms. So the patient will present to an emergency. When congestive heart failure, so you were considering that to be CHF or you were considered to be pneumonia, and you have given the standard medical treatment for both. So like the congestive heart failure, you have given the drugs which can decrease the preload. In the pneumonia, you have given antibiotic, etc. But still, it is not able to be improved, so then you should consider to be pulmonary embolism. So that is also correct. The patient with high clinical likelihood of venous thromboembolism should first undergo D-dimer testing alone without obligatory measures. This is wrong. This is to be done if the likelihood is low. So coming to we have seen that pulmonary embolism, how we have to treat it. So for the pulmonary embolism, you suspect it to be pulmonary embolism. Now you have to determine 2-level pulmonary embolism Wells score. If the Wells score is more than 4, it means it is high likely, it's a high risk population. If the Wells score is less than 4, it means it's unlikely, it's a low score. So if it's a high score, which the question is asking that the patient with a high clinical likelihood. So they are saying that there is a patient with high clinical likelihood. High clinical likelihood means the Wells score is more than 4. So in that case, you have to go for the CTPA, which is computed tomography pulmonary angiography, immediate CTPA, or interim therapeutic anticoagulation while awaiting CTPA. So you have gone for CTPA, and till the time the report is awaited, you have to go for the anticoagulation. If the CTPA is positive, it is showing yes it is pulmonary embolism, then you have diagnosed pulmonary embolism and offer or continue treatment. But if its CTPA is negative and you still think that's a DVT, then you go for the proximal leg vein ultrasound. If you think no, there's no DVT, CTPA is also negative, then stop any anticoagulation and think about other diagnosis. Second thing is that if the score is less than 4, so now it's a low risk patient, then you have to go for the D-dimer test and result will come in 4 hours. And in the in between time of the 4 hours, you can go for the therapeutic anticoagulation therapy. Now again D-dimer is positive, then you go for the CTPA. So ultimately you have to go for CTPA. Okay, if the D-dimer is negative, then stop any anticoagulation, think about other diagnosis. So this is about the pulmonary embolism. So this would have been if there is a high clinical likelihood, go for the CTPA, sir. Don't wait for the D-dimer testing. If it's a low clinical score, then you can go for the D-dimer testing. And if the D-dimer testing is coming out to be negative, then only you will avoid doing for CTPA. But D-dimer test is positive, then again you have to go for the CTPA. That you have to remember. If the high clinical likelihood, what is high clinical likelihood? Well score more than 4. Well score more than 4 means there's a high clinical likelihood. If score less than 4 means there is low likelihood. Then it's a high clinical likelihood, go for the CTPA. If it's a low clinical likelihood, go for the D-dimer testing. If it comes out to positive, again come for the CTPA. So that's the wrong option. Okay, so answer will be only 1 and 2, and this is the diagnosis that whenever you cannot explain the breathlessness, the patient is coming to emergency, you have thought for CHF, treated for CHF, no result. You were thinking about pneumonia, treated for pneumonia, no effect. Then you were going for the well score and find out that it can be pulmonary embolism, and then go for CTP or D-dimer according to the risk that you have find out by the well score, and then go for it. You have talked about. So answer is 1 and 2. Answer will be A, 1 or 2. Now coming to the question number 9. Consider the following criteria. So which of the following criteria, if present in the pleural fluid, will indicate an exudate? That this is an exudate. So the criteria is Light's criteria. So this is Light's criteria for distinguishing from pleural transudate and exudate. So you have the pleural effusion. So the pleural effusion, and you have drained it. You have drained it. You have aspirated it. Aspirated the pleural fluid. And you sent it for the biochemical investigation. You send it to biochemistry lab, biochemical investigation, and you have to find it out that rather it is either transudate or it is exudate. Why? Because the diagnosis for both of them, the condition causing both of them are different. It either the transudate or the exudate. So Light has given this criteria. This is the Light's criteria. So what the Light says, it is said that exudate is likely. So that fluid, that the pleural effusion is exudate if one or more of the following criteria are met. So if out of 3, even if 1 is met, you will call it to be the exudate. What is it saying? If the pleural fluid protein ratio is to serum protein ratio is more than 0.5, it means it is an exudate. Or if the pleural fluid LDH is to serum LDH ratio is more than 0.6, then you have to consider it to be the exudate. Or if the pleural fluid LDH is more than the 2/3 of the upper limit of the normal serum LDH. So whatever is the lab upper limit of normal serum LDH, if the pleural fluid LDH comes out to be more than 2/3, if it comes out more than 2/3 of that upper limit of normal serum LDH, you have to consider to be exudate. So Light criteria says that out of 3, even 1 is met. So then we will be calling it to be exudates. Now coming to option, what is it asking? It is saying that out of the above criteria, if present in the pleural fluid, what will indicate it to be an exudate? When will you say that it's exudate, not the transudate? So coming to Light criteria. So pleural fluid protein is to serum protein ratio more than 0.5. Yes, this is the first Light's criteria. Second is pleural fluid LDH, lactate dehydrogenase, is to serum LDH ratio more than 0.6. Yes, again this is the second Light's criteria. Then pleural fluid LDH is more than 2/3 of the upper limit of the normal serum LDH. Again, this is the third Light criteria. So it will be considered exudate if any one of them is present. So answer will be D, 1, 2 or 3. So this is the Light criteria of diagnosis that either this is exudate or transudate. Coming to another question. Which of the following statements are correct with regard to the clubbing? So we have seen the clubbing. Clubbing is the finger, and it is seen in the fingers apex that you've seen there. The nail bed grows. So which of the following statement correct with regard to the clubbing? So first is it usually affects the fingers symmetrically. Yes, this is correct. All the fingers are affected symmetrically. Second, it does not involve the toes. No, even the toes can be involved. So first is correct, second is wrong. It may be associated with malignant lung condition. Yes. It may recede following the lung transplantation in the case of cystic fibrosis. Yes. So this is correct. So 1, 3 and 4 are the correct answer. 1, 3 and 4 are correct answer. So let's read the text from where it has been taken. So it says that finger clubbing describes painless swelling of the soft tissues of the terminal phalanges, causing increased longitudinal and lateral convexity of the nail. Upward displacement of the proximal nail margin causes the anteroposterior diameter of the finger at that point to exceed that at the distal interphalangeal joint. It also removes the normal hyponychial angle between the proximal part of the nail and the adjoining skin. Clubbing usually affects the finger symmetrically. So from here, the question has been framed. So clubbing usually affects the finger symmetrically, and it commonly also involves the toes. So second option was taken from here, but can be unilateral if it is caused by proximal vascular condition. For example, this AV shunt, atriovenous shunt for dialysis. Then in that condition, there will be only unilateral clubbing. So next time they can ask you the question that in which condition will you find unilateral clubbing? So one of the options will be AV shunt for dialysis. So next time in the emergency, in the OPD, you see a patient on dialysis from whom AV shunt has been created, go and see his fingernails. You will find the clubbing. Although clubbing is usually idiopathic, it can be associated with suppurative or malignant lung condition. So the third option has been framed from it. So it is associated with malignant lung condition. Yes, it is with the suppurative lung condition. Yes. Clubbing may recede. So fourth option is from here. Clubbing may recede if the underlying condition resolves following lung transplantation for the cystic fibrosis. So there's a patient for cystic fibrosis. You went for the lung transplant. Now you see that there was initially clubbing, but there's no clubbing now after the lung transplant. So differential diagnosis for the finger clubbing is congenital or familial. So we have talked about it can be idiopathic in 5 to 10% of the condition. In the case of acquired, the condition can be thoracic. About 80% there can be chronic suppurative condition. There is pus formation like primary pulmonary TB, bronchiectasis, lung abscess, empyema, or cystic fibrosis. There can be malignant condition as well, like tumors like lung cancer, or benign like mesothelioma, fibroma. It can also occur in the case of pulmonary fibrosis. In the case of cardiovascular condition, it is cyanotic congenital heart disease like tetralogy of Fallot, or infective endocarditis, you can see it, or atriovenous shunt, or aneurysm, for example, we have talked in the case of dialysis. AV shunt is made. In the case of GI conditions also, so as a gastroenterologist, you should also see it because it can occur in the cirrhosis, it can occur in inflammatory bowel disease, and one of them can be celiac disease. Others like thyrotoxicosis, which is also thyroid acropathy, in the case of primary hypertrophic osteoarthropathy. So coming to question again, first option, it usually affects the finger symmetrically. This is correct. It does not involve the toe. No, it can involve the toes. It may be associated with malignant lung condition. Yes, both malignant condition as well as the suppurative condition. It may recede following the lung transplantation, cystic fibrosis. Yes, this is correct. Now coming to the 11th condition. 11th question. Consider the following statement regarding the Lofgren syndrome. So Lofgren syndrome is seen in the case of the sarcoidosis. So first is, it is an acute illness and is more commonly seen in the female. Yes, this is correct. It is a clinically distinct phenotype of the sarcoidosis characterized by the peripheral arthropathy and uveitis. Yes, this is again correct. So the condition was sarcoidosis, but the patient is now presenting with a peripheral arthropathy, and there is inflammation in the uvea, so there is uveitis in the eye. Clinical features include fever, erythema nodosum, and bilateral lymphadenopathy. So this is again correct. So 1, 2, 3, all the options are correct. So D will be D, 1, 2, and 3. So all the options are correct. Now coming to the source from where it was asked. So Lofgren syndrome. So sarcoidosis is considered with other DPLDs, as over 90% of the cases affect the lung, but the condition can involve almost any organ. Lofgren syndrome is an acute illness. First option was taken from here. Acute illness characterized by the erythema nodosum, peripheral arthropathy, uveitis, bilateral hilar lymphadenopathy, lethargy, and occasionally fever can occur. Is often seen in young women. So it is commonly seen in women. So this was the first option. Now coming to second, alternatively, bilateral hilar lymphadenopathy may be detected in otherwise asymptomatic individual undergoing a chest X-ray for other purpose. So you went for chest X-ray for some other purpose, and now you are seeing there is a bilateral hilar lymphadenopathy, and then you can diagnose it. Pulmonary disease may also present in a more insidious manner with cough, exertional breathlessness, radiographic infiltrate. On the chest auscultation, it is often surprisingly unremarkable. Fibrosis occur in around 20% of the cases of pulmonary sarcoidosis and may cause a silent loss of lung function. Pleural disease is uncommon. Finger clubbing is not a feature. Complications such as bronchiectasis, aspergilloma, pneumothorax, pulmonary hypertension, core pulmonary have been reported but are rare. So this was about the Lofgren syndrome, which is seen in the case of sarcoidosis. It is an acute illness. It is commonly seen in female, and it is characterized by peripheral arthropathy, uveitis, and the patient can present with fever, erythema nodosum, and bilateral hilar lymphadenopathy. So this was the question number 11. Now coming to the question number 12. Which of the following investigation may be used for the diagnosis of the pulmonary tuberculosis? So this is very common in India. So in which of the following conditions will you go for this investigation? So first is the NAT, nucleic acid amplification. So this is very common. We are in the national program, it is there that we have to go for the CB NAT. Okay, then culture in the Middlebrook medium. Yes, this is correct, because for the culture we only remember that the TB is cultured in the case of the LJ media, Lowenstein-Janssen media, but no, Lowenstein-Janssen media is also used for the pulmonary TB culture, and Middlebrook medium is also used for the pulmonary TB diagnosis. So if we see this is known as the Middlebrook media. This is your Middlebrook media, and this is your green converse, the LJ media. So this is your LJ media, LJ medium for the culture of TB, and this is your Middlebrook media, Middlebrook media, which you can see here. So Middlebrook media is also used. Then the light emitting diode fluorescent microscopy with Oramin staining. Yes, this is again we also use the fluorescent staining. So this you can see there is a microscope Oramin related sputum microscopy. Then peripheral blood smear. No, there is no use of peripheral blood smear in the case of pulmonary tuberculosis. So answer will be A, 1, 2, and 3. So 1, 2, and 3 will be the correct option. So 12. So the most important lesson to be taken from this question is that Middlebrook media is also used for the pulmonary tuberculosis, because we generally remember LG media to be for the pulmonary tuberculosis, but no, Middlebrook media is also used. Then CB naught, we always remember, we will do it correct. Then fluorescent staining, we all know that it is used, so with the Oramen staining. So answer will be 1, 2 and 3. Peripheral blood smear has no role in the case of pulmonary tuberculosis diagnosis. Now coming to other question, the distance walked in 6 minutes. So you've always seen that your pulmonologist is going for the distance walked in the 6 minutes test. Now, is an indirect measure of which of the following variables of the Bode index. So Bode index, where is it used? It is used to assess the prognosis in the case of COPD. So they can ask you for the next time that what is the index which is used for the COPD prognosis. So COPD prognosis, we use the Bode index. Bode index. Now, coming to first Bode index, then we will go for the option. So it is saying that the COPD has a variable natural history, but is usually progressive. It keeps on progressing. The prognosis is inversely related to the age and directly to the post-bronchodilator FEV1. Additionally, poor prognostic indicators include weight loss and pulmonary hypertension. So there's a composite score which is taking all of them, is known as the Bode index, which assists in predicting death from the respiratory and other causes. Okay, so coming to the calculation of the Bode index. So for the Bode, what is Bode? BODE. So B stands for the body mass index, BMI. So we have seen there is a BMI, body mass index. If it is more than 21, the score will be 0. If it is less than 21 or equal to 21, the score will be 1. Okay. Now coming for the O. What is O? O means airflow obstruction. The degree of airflow obstruction. O for obstruction. So BOD obstruction. So for O we have the FEV1, forced expiratory volume in 1 second. So if it is more than 65, then score is 0. 50 to 64, score is 1. 36 to 49, score is 2. Less than 35, score is 3. Then we have the D. D is for the measurement of dyspnea. So dyspnea, how will you find out the dyspnea? You will go for the MMRC dyspnea scale. So this MMRC scale 0 to 1, 0, 2, 3, 4 accordingly you have to give. For the E is for the exercise capacity. So what is the exercise capacity of this patient? Exercise capacity. So exercise capacity, for example, you have to go for the distance walked in 6 minutes. The question is about this only. So distance walked in 6 minutes is actually calculating your exercise capacity. So coming to question. So they are asking that distance walked in 6 minutes in the Bode index is used for calculating what? So BMI, no. For the BMI, we can simply go for BMI calculation. Degree of airflow obstruction, no. We go for the FEV1. Severity of dyspnea, again, no. We go for the MMRC score. Exercise capacity, yes. We go for the exercise capacity. Distance walked in the 6 minutes for the exercise capacity. So this is the correct answer. So you have to remember one thing more, that Bode index is for the COPD. They can ask you Bode index is for the COPD. If you want to go for the MMRC dyspnea scale, this is 0, 1, 2, 3 and 4. 0 means no breathlessness except with sternus exercise. 1 is breathlessness when hurrying on the level or walking up a slight hill. Score 2 is walk slower than contemporaries on level ground because of the breathlessness or has to stop for the breath when walking at own pace. Then 3 stops for breath after walking about 100 meters after a few minutes on the level ground. 2 breathless to leave the house or breathless when dressing and undressing. So even on the normal activities, like dressing, undressing, or when you are leaving the house, so these are very normal activities, sir or ma'am. So score will be 4. But if you have to walk for 100 meters or few minutes after walking, if you develop it, score is 3. But if you have to walk slowly than contemporaries because of the breathlessness, even on the level ground, or you have to stop for breath when walking at own pace, then it's a 2. Or whenever you are doing some slight hill, you are walking or you are hurrying up for the level, you are going for breathlessness, it's a 1, and there's no breathlessness, then its grade is 0. Now coming to question number 14. A 65-year-old female, so the 65-year-old female, so it's an old female, a stone cutter by occupation, so she was stone cutter for occupation, had multiple well circumscribed nodular opacities in the upper and the middle zone of the chest x-ray. So you went for the chest x, and what you are seeing, there's a nodular opacities in upper zone and the middle zone. Plus, there's mediastinal lymph nodes which shows eggshell calcification. Now, this is very characteristic. Which of the following is the most likely etiology? So it's a silicosis. How you have diagnosed is by her occupation, that she was stone cutter, axial calcification, and then nodular opacities in upper and middle zone. So answer will be silicosis. Silicosis. Bicyanosis is seen in the case of when she was in the cotton industry. Cotton industries it is seen. Berylliosis because of beryllium, siderosis because of the iron. Berylliosis because of the beryllium. Again there will be bagasosis. Bagasosis is because of sugarcane. In the sugarcane industry when she was working. So this is about the silicosis. Again the ceramic industry, person is working in ceramic industry, or stone cutter, this can be asked. Anthracosis is seen in the case of the coal industry. And this all occupational disease, the involvement of lung in the case of occupational disease, all come into the pneumoconiosis. So 14th answer will be silicosis. Now, which of the following are complication of acute pancreatitis? So there was a patient in emergency, acute pancreatitis. You have admitted the patient, started the treatment, but what are the complications that you should anticipate that it can come? So it is hypoxia. Yes, the patient can go into ARDS. ARDS is one of the complications of acute pancreatitis, and because of that there can be acute pancreatitis, hypoxia. Hypercalcemia, no. There is generally hypocalcemia. There is hypocalcemia. Hyperglycemia, yes, because of the effect on the islets of Langerhans. On the islets of Langerhans, there are alpha cells, beta cells, etc., which are producing insulin, glucagon. So hyperglycemia can occur. Reduced serum albumin, yes, this can occur. So answer will be 1, 3, and 4. 1, 3, and 4. Not hypercalcemia, but it's a hypocalcemia. So second will be wrong. Now coming to the text from where it has been asked. So complication of acute pancreatitis. So there could be systemic complications. There can be pancreatic and GI. Systemic, there SIR, systemic inflammatory response syndrome. Why is it occurring systemic inflammatory response? Because there is vascular permeability from the cytokines. There will be platelet aggregating factors. There will be kinin release. Then hypoxia because of the ARDS. Why there is ARDS? Because there is occurrence of microthrombi in the pulmonary vessels. Then there is hyperglycemia. Hyperglycemia because disruption of islets of Langerhans with altered insulin or glucagon release. Then there will be hypocalcemia. You have to remember there will be hypocalcemia, not hypercalcemia. So hypocalcemia is sequestration of calcium in the fat necrosis, and there will be fall in the ionized calcium. Then there's reduced serum albumin concentration. So this was again asked. The serum albumin concentration will be reduced. Why? Because the capillary permeability has increased, and that's why the albumin has leaked out from the serum. So there was leaking of the serum. In the pancreas, there can be necrosis, non-viable pancreatic tissue, and peripancreatic tissue death frequently infected. There will be abscess, circumscribed collection of pus close to pancreas and contain the little or no pancreatic necrotic tissue. There will be pseudocyst, disruption of pancreatic duct. There will be pancreatic ascites or pleural effusion. Then there is a disruption of pancreatic duct. Now GIT, upper GI bleeding can occur. Why? Because of the pancreatitis there was gastric or duodenal erosions. There can be variceal hemorrhages because of the splenic or portal vein thrombosis. There can be erosion into the colon. Why? Because of the pancreatic pseudocyst. So pancreatic pseudocyst can cause many things. Yeah? Then duodenal obstruction, again by the compulsion by the pancreatic mass. Obstructive jaundice because that mass has compressed the CBT, common bile duct. So there can be obstructive jaundice, there can be duodenal obstruction, there can be erosion into colon, there can be variceal hemorrhages, and there can be upper GI bleed. So there are various complications of pancreatitis. That's why acute pancreatitis is to be managed well aggressively. Now there's a gold standard for diagnosis of the celiac disease. So we know endoscopic small bowel biopsy. This is the gold standard. This is the gold standard. We can see even this was from the text. So endoscopic small bowel biopsy is considered as the gold standard for the celiac disease. So this has been taken from here. So endoscopic small bowel biopsy. They are saying that endoscopic appearance should not preclude biopsy as the mucosa usually look normal. So you went for the endoscopy, you saw okay, mucosa looks normal, it means it's not celiac disease. No sir, this is not correct. You have to go for the biopsy. As the histological changes can be patchy, an adequate number of the biopsy. How much you have to take? 4 biopsies from the second part of the duodenum plus 1 from the duodenal bulb. So 4 plus 1. You have to take 5 biopsy samples. 4 from the second part of the duodenum and 1 from the duodenal bulb. The histological features are usually characteristic, but other cause of villus atrophy should be considered. Okay, now antibody testing is also important, like tissue transglutaminase, endomycin antibodies. These are important, but the gold standard